Hello, my name is Antonio. I'm a UK and US trained anesthesiologist surgeon. I get a lot of calls from my general practitioner colleagues regarding how they would remotely evaluate patients with eustachian tube function, especially in the light of the recent concerns for both patients and practitioners with airborne infections. And here's a piece of how I would evaluate such patients. But before I go into that, I'd like to just give a few brief words on the normal anatomy and physiology of hearing. Sound is essentially compressed airwaves, and this is collected by the pinna and goes inside the external air canal, where it moves the drums and is converted into mechanical energy. The mechanical energy is amplified by the ossicles, which require an air-containing space in order to be more efficient, in order to reduce the friction of the movement. And this energy is converted into electrical impulses in the cochlea, which the brain uses and processes for sound. Now, the eustachian tube is a 1.5 inch connection between the middle ear space and the throat, which is how the body circumvents the problem of having a middle ear space within an enclosed cavity. And this eustachian tube may be blocked by either structural factors or physiological, because it's mainly essentially surrounded by a lining, tube of the bone and cartilage, which is also controlled by muscles. Now, the patients typically would complain of symptoms such as orophones, fluctuating hearing loss, sometimes tinnitus, hyperacusis, which is essentially sound intolerance. They may well complain of dizziness, or orthophony, which is basically hearing their voice reverberate, usually unpleasantly. And this may well vary in intensity and also affect how they respond to various things associated by anxiety. The patients may present with a typical history of having traveled recently or had an upper respiratory tract infection. The patient may also give a history of a recent change in altitude, either mountain climbing or diving. You have to be aware of patients with long-standing history with eustachian tube problems, which you'll probably find in patients with Down syndrome and other craniofacial abnormalities like patients with trichocolitis, which is why you want to observe whether there are any obvious craniofacial abnormalities when you see these patients. These craniofacial abnormalities may vary between altered dentition, low set ears. They may well have an obvious nasal deformity, which may have been caused by trauma. You also want to be aware of patients, especially those from of Indian or Chinese extraction, patients with cranial nerve palsy, and though this may well affect all ethnic groups, because I do see quite a few of these patients amongst West Africans as well. You also want to look out for patients who may have a cleft palate repair, and they may well give you that in their history, or recent development of acromegaly, or any other hormonal changes, which may well either give you a frank eustachian tube dysfunction where it's blocked, or may predispose them to a pateless eustachian tube. Now, in terms of diagnosis, you clinically diagnose by requesting the patient has a tympanometry, whereby they check the pressure levels and see how it moves in relation to the how the drum moves in relation to the pressure imparted through the air canal, and this is done by an audiologist. What you can infer this by your history and also your video consultation may well play a part in your evaluation, because during your video evaluation you'll have looked for cranial abnormalities, deformity of the nose, scarring of the lip, abnormality of the pinna, which may be low set in relation to the maxilla or mandible, obvious maxillofacial deformities. All this will point to a patient with chronic eustachian tube dysfunction. To also be aware that you may well have associated cardiac, renal problems, which will need to be addressed at some stage when you're evaluating these patients, especially if the symptoms persist. In terms of treatment, you can treat them conservatively by encouraging to do valsalva maneuvers. One which I would advise is asking to blow their cheeks out with a compressed nose and swallow afterwards. because most of the things that would encourage the eustachian tube open would be chewing, swallowing, and trying to pop your ears. Popping your ears is not necessarily a sinister thing. It may well be the mid-ear space correcting itself, although it may well be a feature of palatal myoclonus, which is a completely separate entity due to the contraction of the palatal muscles, and that I will address at another later stage. Other ways of dealing with eustachian tube problems, if it's due to a patulous eustachian tube, you want to look at advising the patients to either sniff in order to close the eustachian tube intentionally, although this would not be advisable if the patient has otitis media. You could ask them to place their heads between their knees, because lowering their head may well cause the eustachian tube to close over. In terms of surgical procedures, grommet insertion in adults, you want to pass the postnasal space, or in children, if the adenoids are enlarged, we would also take the adenoids out at the same time. But in terms of treatment you can offer in the clinic, you could ask them to use nasal steroid sprays for at least 8 weeks, and you need to ask them to apply it correctly, aiming in the direction of the ear or the side that they're applying the sprays, and avoiding sniffing and swallowing at the same time, because this would encourage the steroid medication to go down the throat, which is not where you want the steroid sprays to take effect. Other surgical procedures include directly dilating the eustachian tube with a balloon sinuplasty. Well, these are in the realms of specialists, and they will do well to refer patients that have persistent tissue problems. I hope you find this piece helpful. You can contact me either through my website, www.tonoa.com, or by email on tonoa@hotmail.com or ent@tonoa.com. You could also view further videos on my YouTube channel, tonoa.com ENT surgery videos. Thanks for viewing this, and thanks for listening.